So let's tackle hypertonic first. I think in clinical circles, it's long been discussed that this is an inappropriate term. You've probably heard that.
You're listening to the In Your Pants podcast. I'm your host, Dr. Susie Gronsky, your penis-friendly pelvic health physical therapist, sex counselor, and educator, helping you get in the know down below. Hi friends, Dr. Susie G here, and welcome to another In Your Pants podcast. On today's show, we are going to be debunking the myths and misconceptions around, quote, air quotes here, tight, overactive, non-relaxing, hypertonic pelvic floor muscles. So many names with no conclusive data to support either of them. And to help debunk these misconceptions that are running rampant on social media these days is researcher Rachel Werman. Rachel and I dive into the depths of her research to determine whether greater tone or higher activity equals pain, and is the same applicable with pain causing greater tone or higher activity. You don't want to miss this episode. So before we dive into the juicy parts of today's show, let me formally introduce Rachel Werman and her fantastic accolades here. So Rachel is a licensed physical therapist in the United States who has extensive dual training, clinical and teaching experience in both musculoskeletal and pelvic health physiotherapy. She has worked as a musculoskeletal and pelvic health provider in the private outpatient setting, and most recently held a senior physical therapy position as a pelvic health provider in the women's health and urology clinics of a large medical group in Northern California. She has held part-time and adjunct faculty positions at both the California State University at Fresno and Sacramento, as well as a clinical lecturer position at the University of California at Davis School of Medicine, the Division of Pain Medicine. She received her Bachelor's of Science in Biopsychology with an emphasis in visual neuroscience and a minor in exercise and health science from UC Santa Barbara in 2002. Her Master of Physical Therapy from CSU Fresno in 2007, and Doctorate in Physical Therapy from the Joint Program at UC San Francisco and CSU Fresno in 2008. In 2019, she was awarded a full scholarship from the University of Queensland for a PhD candidacy as a result of her advisors, Paul Hodges and Ryan Stafford, being awarded a large NHMRC grant titled Efficacy of a Personalized Pelvic Floor Muscle Training Program on Urinary Incontinence After Radical Prostatectomy, a randomized clinical trial with embedded physiological studies, where she is working on the embedded physiological studies. Her research focuses on the study of pelvic health outcomes measures and male pelvic health, and her thesis was confirmed in 2020 with the working title Toward an Understanding of the Role of Pelvic Floor Muscle Tone in the Examination of Male Pelvic Health Conditions, Investigation of Concepts of Greater Tone, and a Preliminary Framework for Down Training. So, she is certainly someone to keep on your radar for all things clinical research for men's pelvic health. I hope you enjoyed today's show.
Rachel, thank you so much for being on the show today.
Thanks for having me.
Well, we're gonna dive right in because this is a topic that is certainly very passionate, a passion of mine. Certainly having to deal with the pelvic floor, but also this your research in the male pelvic health realm. Is this such an amazing conversation to have with you and to go over your most recent systematic review that came out about tone, pelvic floor tone and overactivity and etc. So there's a ton of hype on social media, right? We no argument there about how, your pelvic floor tightness, overactivity, hypertonic in air quotes, non-relaxing in air quotes, cause all sorts of problems, right? Like pain, sexual dysfunction, urinary issues, bowel issues, etc. So based on your research and your most current systematic review, what language should we really be using to describe the state or the health of pelvic floor muscles, and why?
Yeah, it's a really great question. And so this is systematic review, which is regarding the evidence for increased tone or overactivity of the pelvic floor muscles in pelvic health conditions, um, was designed to look at outcome measures and to look at study methods. And then we also pieced in terminology. And that's because we're not speaking the same language.
Mm-hmm.
And it's problematic. And it was one of the things that led me to design my thesis in the way that I did. So let's tackle hypertonic first. I think in clinical circles, it's long been discussed that this is an inappropriate term. You've probably heard that,
Yes.
right?
Uh-huh.
Because the majority of pelvic health cases are not cases with central nervous neurologic problems, such as a spinal cord injury,
Mm-hmm.
which would be the most appropriate context for this term. Yet we continue to see and hear this term all over social media, as you mentioned, and from self-proclaimed guru pelvic PTs um, who are proclaiming that they are evidence-based. And before our systematic review came out, there was actually the International Continence Society came out with a terminology report that also suggested that we not use the term hypertonicity.
Mm-hmm.
And so this systematic review actually found that hypertonicity is the most commonly used term in the clinical literature, but never was it used in the clinical literature in the context of neurologic pathology.
Interesting.
Um, and so I think that this is it's a problem because it's actually inaccurate. And again, not just our systematic review, but reports prior to this have stated that. And we've discussed it for a long time. So at this point, anyone using this term in the absence of neurologic pathology is currently not practicing evidence-based practice. That's just full stop.
Mm.
In the mid-2000s, there was an effort led to reduce the use of this term with a substitute term, overactive. In fact, there was a textbook by Tali Rosenbaum and Anna Padova that was published in 2016 called The Overactive Pelvic Floor.
Yes.
However, this is also an inaccurate term. So first, if we think about tone, it is made up of two muscle properties: the active tone, which is the nerve activity that causes the muscle to contract, and passive property, which is essentially all the other content of muscles that aren't active. So the connective tissue, the water content, etc., that give us resistance when we push on a muscle. So overactive is a term that is best used when we have used a measure of the active component of tone. And the only measure to do that is EMG.
Mm.
There's also been a trend for therapists, I think, to move away from using EMG.
Yes.
Problematic. So if EMG was not used as a measure, we cannot use a term that describes muscle activity. So if you've not used EMG, we can't say overactive. And we saw a lot, the term overactive frequently used when, say, something like digital palpation was the measure, not EMG, which is technically inaccurate. Terms like non-relaxing pelvic floor do not make sense when describing a muscle that requires at rest a certain amount of tone to maintain continence. Makes sense, right?
Mm-hmm.
But if we say non-relaxing, well, we don't want these muscles to completely be turned off. So unless we want to wear Pampers all the time. So In some contexts, though, non-relaxing may be an appropriate term. For instance, if we're measuring function. And usually this is found in the urologic and the colorectal literature. So if the assessment we make is during bowel or bladder voiding, in that case, we want the muscle to turn off fully and relax fully to allow for passage of bowel or bladder content. So it might be appropriate to use it there. Now, from our systematic review, we now know that there is not very much normative data. So terms recently proposed, and this was also by the ICS terminology document, such as increased tone, are also inaccurate. So in the absence of normative data, we can't state that something is increased as we have no normal values to compare that against.
Right.
We also cannot use that term on an initial evaluation because we don't have prior values from the previous test.
Makes total sense.
Right. So the best term to use at this time is greater tone because it can describe the comparison of an individual to another individual. And that's all we can say. That's based on our reference as a clinician. This person had greater tone than this person.
I see. And that's within, so as a clinician doing an assessment, that clinician is using their subjective experience with previous individuals, not just that particular individual, or is it just within that individual and assessing whether tone was greater or not with reassessment?
It can be both.
Okay.
It can be both. Yeah. And if we look at evidence where there is a healthy comparison, we can also use that term, greater tone. And if we are using EMG, and in the absence of good and convincing normative data for EMG, we can say higher activity. So this activity was higher than that activity. And higher is a better description than greater, just because when we're looking at an EMG, we're looking at lines going higher. It's simple. I like to keep things simple. I mean, the thing that's really fascinating, Susie, about this is that it was really complex to arrive at that. But now that we've arrived at this new knowledge, it's like, oh, duh, this is so simple. Why didn't we think about this? Why haven't we been speaking this language all along? But anyway.
It totally makes sense. And I think this change in some cohesiveness with language and actually having biologically plausible and also some data to back up what it is that we're actually examining, assessing, and treating.
Yeah.
Does that's just, there's a lot of confusion there, right? Because depending on how I'm defining what I'm defining when I'm evaluating someone, then my treatment offerings are going to be based on, my preliminary definitions and what I think those mean and what I think I'm actually doing. And is it actually, are we actually changing what we're changing or what we're assessing, right? There's just a lot of confusion.
We're so excited to get to the next, latest, and greatest treatment. And so we've really bypassed the basics. I think sometimes, we're taught the basics and then we think, oh, that's really basic. So I'm going to move on to this other advanced treatment concepts. And we sort of we forget that, right? But it's always good to go back to the basics and really consider, we know these things, but we're skipping over it, unfortunately, not thinking through our assessments and what it means and what our measures are actually telling us.
Exactly. Now, this language, as a clinician, I can understand this and this makes sense to me. But when we then go to explain this to the patient, right? Because they're in pain or they have some sort of, dysfunction, certainly, and they're wanting to get help. What is your advice on like the language that we use with our patients and how might that influence their treatment outcomes? Knowing what you know now.
Yeah. I think that's a really important conversation. So I think in terms of language with patients, the best approach is honesty and education, first of all. And I think that the certainty with which we speak or advertise, and especially on social media sometimes, is unwarranted and misleading. And we have to be careful. Generalizations that are made on social media, well, we know better now. And I think that we just went through this in other contexts. So I think what I see in terms of the tone terminology is hypertonicity causes pain.
Right.
And that's a very common one. And as we just discussed, hypertonicity is not factually accurate term. And those generalizations and that language is problematic because, well, we just went through this, as I said, in other contexts, that treatment is between a patient and a provider. And if we throw it out there as a, one size fits all, then it's problematic, because what happens when we are so certain in the absence of evidence and a basis for that certainty, and then the patient does not get better. What do we do then? We were so certain.
And the patient was certain and was almost guaranteed that they're going to get a certain result, and it didn't happen.
So I think it can be a little bit damaging and frustrating, and it just repeats the cycle of frustration for the providers, for the patients. Some of my colleagues down here at the University of Queensland are working on the sociologic aspects of the biopsychosocial model, so putting the soc back into biopsychosocial. And the words matter, and they just put out a paper recently talking about uncertainty in clinical practice. And it's really fascinating, but it turns out that patients seem to actually prefer and be okay with the fact that we're uncertain, as long as we put it out there in an honest way. So if we can humble ourselves to that uncertainty, I think we'll get further.
Wise words. Wise words. Yes. Yes. So speaking of, you mentioned this briefly in your discussion just now about, well, does greater tone or higher activity necessarily mean pain in all situations? What are your thoughts?
We don't know. And not necessarily.
So
that's a simple answer.
Right. I love it. I love how simple you are, Rachel. This is great because my brain can only handle simple. Okay. This is great. So what I'm hearing is, so someone might have experienced pain in their body or in their pelvis and have no signs of greater tone or higher activity, but still experience pain, and vice versa may be also true as well.
Right.
Okay.
Yes. So if we find tenderness on palpation, it doesn't necessarily mean higher activity. And this assumption is made all over the clinical literature and clinical practice. If there is pain, it is assumed that there is tone. This comes up, well, what you'll see in the clinical literature is the measure that was performed was pain on palpation. And then the clinical output or interpretation is trigger point. And trigger point, by definition, has greater tone as a background. And so there's an assumption made, and it may not actually be the case. One does not equal the other. They may coexist, but they also may exist independent of each other. So the best way to find out is to measure both. So again, we'll just keep it simple. Measure pain, measure tone. See what's there. Just don't make an assumption. Palpate the muscle using the Riesing scale to grade tone. Then use the numeric rating scale to measure the pain.
Can you
measure the
briefly,
measure.
oh, sorry, Rachel, can you briefly walk us through the is it reason scale?
The Reasoning scale, yes. So the Reasoning scale is the only palpation measure that measures resistance to passive stretch, which is, well, so let me just back up a little bit. So when we are measuring stiffness from a physics standpoint, it's a resistance to passive stretch by a tool that gives us a force output newtons per meter.
Mm-hmm.
Our finger does not give us that measure force.
We think so, but
it doesn't. So we push into a muscle, and then our brain interprets that based on our experience. So what we're measuring is actually not stiffness. We call it that sometimes. It's tone based on our subjective interpretation. But the Reasoning scale is basically we push into the muscle and we measure we give that interpretation of that resistance to passive stretch, and we grade it on a scale. 0 is normal, +1, +2, +3 is greater tone, and -1, -2, -3 is lesser tone. So it's a 7-point scale. And the Reasoning literature also has a scale for the external anal sphincter muscle, which is a 3-point scale. 0 is normal, +1 is greater tone, and -1 is less. The reliability of the 7-point Reasoning scale is somewhere in the range of 0.2 to 0.5. So it's moderate, has moderate reliability. There are a lot of different scales that are in the literature that are sort of invented by the researchers, and they haven't been tested to be reliable. The recent terminology paper by the International Continence Society has suggested that we just use increased tone, normal, and decreased tone. And that's because of a paper that came out, I think in 2019 by Melissa Davidson, where they actually looked at the Reasoning scale and found out with a lot of different measures that it may actually not be that accurate, but it is the most accurate thing that we have, unfortunately. Right. The nice thing about the Reasoning scale is that we can superimpose it onto the ICS scale, which is, I think it's necessary, depending on the clinical setting that you're practicing. If you're working with insurance companies and you need to be able to show continued progress, then it's nice to have that extra 3-point scale, rather than, just going from increased tone to normal, because that probably doesn't happen. And I guess I could say also that from the Melissa Davidson paper, what therapists are really good at is knowing when there's really, really high tone and really, really low tone. So the reason that ICS did that in part, I believe, is because we're not as good at distinguishing between that +1, +2, +3. So we do have to be careful. So I do say that with some caveat.
No, that's super helpful, because at least that gives some guidance of having some sort of consistency with what we're assessing and the meaning behind what we're assessing. And also helpful to know that a lot of the scales that one might read in clinical research were created by the researchers in order to defend their research, essentially, or to make sense of their research. Maybe defend is a big word, and I shouldn't use that word. I'm not
right, and I would say clinical researchers. And so sometimes what you'll see is that you've got a research team and you've got some pelvic health physical therapists that are sort of influencing that. And so
That makes sense. I mean, that makes sense. Yeah, that makes sense. But I'm glad they're having this conversation about what to look for when we're actually reading papers, when we're looking at things on social media and reading and health literacy and how accurate that is and updating our language and updating our knowledge because I think it's freeing too. If because a lot of the people I work with too are sometimes, they've been told a lot of things about their bodies that I think prevent them from full recovery because it's almost an unattainable goal of my pelvic floor muscles don't relax or my pelvic floor muscles are, there's tone, there's hypertone in there, there's too much tone, it almost it can be very paralyzing, I think,
Yes. Yeah.
in my opinion. So, okay, there's an interesting paper, and I know we were speaking before we started recording about the Yanni paper from 2022, and it's very rare to see research for men's health, especially in this way. The researchers compared men with chronic pelvic pain to a healthy control. It's a good start. To those without pelvic pain, they did use the surface EMG internal electrode. Awesome, also great. I thought it was very easy to kind of follow the research and things. But what not shocked me really, but what was surprising is that when I saw their data and they compared the controls with both conditions that they were testing, the at rest condition and then the rest after contraction condition. The healthy controls, EMG or muscle activity, was higher than the pelvic pain group. And that's almost counterintuitive to everything that we're told, right? Like, again, thinking that higher activity or greater tone equals more dysfunction or more pain or more symptoms, etc. And this was almost saying, well, that there's a mismatch there. So I would love to hear your thoughts about this paper. And yeah, I would love to hear your thoughts about this paper and their findings.
I think that, first of all, this paper is the first paper to provide convincing evidence because it uses a valid measure. The EMG, as you mentioned, has that healthy comparison, as you mentioned, and there's no application issues. So what we mean by that, and this is how we judge papers in the systematic review, in our systematic review, no applications in the case of EMG means that we want to see that the data was normalized. And normalization of EMG data is really important if you are comparing between cases or between days. And they did all that, and it's great. In fact, the paper would have been in the systematic review if it was published a little bit earlier.
I figured as much. Yeah.
So it's really nice in that sense. I think one of my criticisms of the paper is that it only uses EMG, so there's not a combined measure there. And so we don't have an understanding. And I think to your question, well, they did find that the other nice thing about this paper is that, and we haven't seen this a lot in papers yet, is that they actually took the eligibility questionnaires and they actually delineated out the specific detail. So in other words, they were able to look at the men who had more specifically ejaculatory pain, for instance, compared to, I think it was testicular and maybe anorectal pain. And per the NIH CPSI, I think was the tool they used. So that's really nice. That's really important. That's something I'm really interested in seeing. And so the men with the ejaculatory pain actually did have higher levels. But I guess to answer your question, I've already sort of answered it in that if the EMG activity is lower, but there's still pain there, what in the heck are the combined measures showing us? So what is the passive stiffness looking like? And we can't measure, there's no measure for the passive property of tone. It's sort of a relative concept that a judgment that you would make based on having tested two things, active and passive. And if there's not active there, but there is positive findings on the passive or on the combined measures, then you can potentially make that judgment.
And combined measures, just for clarification, is when you're using an active measure like a surface EMG that actually gives you an output of data, and for example, digital palpation.
Good question. So combined measure means that it can't differentiate between the active and passive properties. So when we do digital palpation and we make a judgment that there's greater tone, we don't know if it's coming from muscle activity or from connective tissue stiffness, for instance.
Okay.
So when we first started doing this review, we were going to judge out all the measures by passive or active. And then we're kind of going, wait a second, that doesn't make sense. Well, we were going to call it mechanical, but that didn't really make sense because all these measures, all measures except for EMG, are giving you an output that is a combination. That's why it's called combined.
I got you. Okay. Of active and passive components to muscle.
Right. So that's why it's really important. And Melanie Moran did this in one of her papers where she was using dynamometry, which is a combined measure. But what she did is she put EMG electrodes on the tip of the dynamometer, which is basically, the dynamometer is kind of like chopsticks that they place into the vaginal canal. We can't use this in men, or we don't use this in men at this point, but it pushes into the muscle. And so what they did with the EMG on the tip of the speculum, the dynamometry speculum, is they put this EMG plate, and then they can push into the muscle, wait for the muscle activity to die down, and then do the passive measure. So that's the closest that we have gotten to doing actual passive measure.
Wow.
Yeah.
That sounds very complicated and difficult. It does. I mean, just to get this data, and I hope people appreciate all the detail that goes into being a researcher when you do it well. I mean, there's so much thought, there's so much detail, there's so many questions, there's so many paths to go down to really have substantial evidence or some sort of conclusion, to make from everything you've gathered. So
there's certainly a lot of problem solving and creativity and getting these measured. These are some of the most difficult muscles to measure in the body. They're very problematic from a research standpoint. So
definitely. Do you get a lot of folks who I always wondered this, that folks who volunteer for studies that have to do with pelvic floor, is it easy to find folks to sign up for these studies?
Well, so no. There are a couple of factors there. We're testing male participants, and I've had this discussion with a number of people. I'm doing this work in this research in Australia. So I would say that the male participants, it's a little bit harder to break into the men's health community here. It's just not, it's not discussed well in the United States, but it's really not discussed a lot here either. And so it has been a challenge. There was one of the studies that I did was done in females prior, and there was plenty of willing participants. So
I see.
There do seem to be some barriers. I had this idea that, once we get past the healthy controls, then, there'll be plenty of patients to test. And I think that there are, but the willingness, and I thought that there would be some willingness there, because my experience in working with men over the years is that they're very keen to help the cause, because there is not a lot that we know about this population, unfortunately. And so, but it's been a challenge and in men with pelvic pain as well. So we'll see.
Yeah. So for all those men listening, and if this is your experience, please connect with your researchers and help your fellow man, in that sense, right? So that's my plug for the the research push. Let us help you better, right? Like let us really do the research, because it is a huge gap with male pelvic health and pelvic pain research for sure when compared to their counterparts, and also a huge gap in the transgender community and non-binary folk and gender expansive people. So yeah, lots of shoes to fill, and so grateful for researchers like you and clinicians like you who take step into this courageously, with a lot of compassion and empathy for the people that you're helping. So thank you. And thank you to your team. So, okay. So one last question here. Well, actually a couple. I have two, if that's okay.
Sure.
The one going back to surface EMG. So numbers. And I'll be honest, I'll be the first one to say that I am one of those clinicians that have threw the baby out with the bathwater when it came to the EMG, right? The biofeedback. No, that's crap, right? And I am actually I'm considering bringing that back after having this conversation with you, after reading your research, after watching your webinars, because I think it has merit, but the narrative around the use of it has changed. And I think that was a really important piece for me is, okay, this makes more clinical sense. And this definitely feels like it's biologically possible and based in science. Whereas the narrative before was very different. So there is how do we know? You had mentioned in your webinar that there's a number out there of 2 microvolts for muscle activity with an EMG. But then you had mentioned too that there are other studies that say average or quote unquote normal is maybe could be 6 to 9 millivolts. So what are your thoughts on do we hold lightly to those numbers? Can we be fairly confident in 2? I don't know. I don't know what to think about that.
I think we need overall more participants to come up with that sort of normative data. The white paper, which was the original one, that if you trace that back, where that 2, I mean, you've heard this in coursework from the get-go, I'm sure, 2 microvolts.
Oh yeah.
So that paper is not super convincing. And there's a couple of interesting findings in that paper. One is that there's a couple of images and explanations of images that are mixed up, which just could be just publication snafus. The EMG image, there's an image of the EMG in there, is actually hand traced. So it's just a little bit sketchy, and it may be that because of how, from the date of that publication and how we did, published images, that was why they did it. But what you'll see on the image, it's really fascinating, is that so EMG is measured over time. So there's a spike in the EMG that actually comes back in time.
Oh, that must be.
And so, yeah, it's just questionable. At any rate, and it could just again be a hand tracing to make the image better, and it just wasn't done well. But yeah, and then the other study is more recent, probably a little bit more convincing, but still, a relatively small population of subjects.
And I
So
didn't. So this new paper showed also an average of 2.
No, so the newer paper is the one that showed closer to 6.
Okay. Okay.
Yeah, it's that information is in I think it's in the discussion section of the systematic review. And I'm sorry, I don't remember the numbers off the top of my head or the author at the moment, but I think it's about 6 to 9 was the resting data.
I think you
And
had
then
mentioned that.
and then there's a number of authors that that have used I think it was 1 to 2 microvolts in it. Yeah, I think it was microvolts, not millivolts. Microvolts in was the resting data for women, and then for men it was 2 to 3, and I might have the male and female reversed on that. But that was based on clinical expertise, and so it's just a judgment call,
Right.
based on experience. So we have to be careful there.
Right. Right. I got you. Okay. Okay. So again, it sounds like to me how I'm understanding this is it should always be applicable to the person or brought back to the person that you're working with, just to connect that back with, is this biologically possible that, because we don't know prior to that person not having pain. I mean, we didn't measure that before. So I don't have that data, right? I don't have anything to really compare to. And it kind of makes it challenging when there's such wishy-washy, inconclusive, like, well, what is kind of normal or average that I can actually go over to make a conclusion that, this number equals pathology or dysfunction, or, because we don't know if that's the case at all, actually.
Sure. And to add to the complexity, the clinical EMG tools that we have do not provide us with the data that we need to do normalization. So so comparing one patient from day to day, so visit to visit, is problematic. It is more, we can do a comparison from early part in the same day to later part. So, pre-treatment and post-treatment on the same day.
Mm-hmm.
And these are some things that I've had some discussion with some of the people working on the SEED project, which is the ISEC group, from the ISEC group, which is the International Society of Electrokinesiology. And I'm trying to put a bug in their ear to help out the pelvic floor clinicians, because we are the ones that are really utilizing EMG the most, even though we've sort of gotten away from it. And I agree with you. I use it a lot. I was a heavy utilizer of it up front, but time in the clinic, I mean, there are all these factors, but like you said, now that I'm looking at it differently, I think one of the criticisms is kind of centered around, this is what you hear a lot in social media. Oh my gosh, I just saw this patient who was at this clinician, and all they did is put him on biofeedback and leave the room and have them watch this and try. So it's really the complaints seem to be centered around the treatment aspect of it.
Mm-hmm.
And we're not just, so we're thinking about it in terms of treatment, but we're not really doing a good job considering what it means from an assessment standpoint. And a lot of times with EMG, you do the assessment and they're hooked up. So there's some findings there. So let's maybe just kind of work on some things, right? And there's certainly times where we use a lot of EMG, or pediatric cases where I think it's really important. Our spinal cord injury patients, that's really important. But I've got away from it in other instances, except for just like every now and again, you're like, something I'm not getting at the answer all these other ways. So let's spend the time to do this. But I guess I just wonder, if we're really considering the muscle properties in this way, would we arrive at a better conclusion earlier, even though it's time consuming? Would we arrive at that conclusion earlier and get to the outcome that we want for the patient sooner? And that's something that we need to look at now.
Right. And so that sounds like knowing, okay, so what's influencing a particular process, right? Or contributions to this very protective, a pain state, pain sensitivity, etc. So uh, this goes back to a question I had here about pelvic therapy being very heavily manual therapy focused,
Mhm.
doing internal work and so forth. Does this research that in the research that and what you've learned so far, has that changed how you utilize manual therapy?
Well, let me just kind of jump off your last question. I was just mentioning that EMG is really problematic, but actually all the measures that we have for tone are problematic. And the same people who are really critical of EMG in our profession are the highest users of digital palpation. And digital palpation is the least reliable, and it's certainly not valid measure that we have of tone. Um, it's actually it's the worst combined measure that we have.
Mm-hmm.
It's very problematic. So I think we need to really take a step back and really think about what we're being critical of.
Mm.
Maybe it's like point the finger back to.
Mm-hmm.
Um, Look, I am a manual therapy trained therapist. I love manual therapy. I think for the right case, it gets us places. Um, I think there have been times. So you're mentioning this concept of manual therapy being sort of the trend, and I think there have been times where trends were the exercise focused, and then we kind of went psych focused, where we've done essentially just talk therapy and no touch or exercise therapy. And think the pendulum kind of always swings. Um, but I think, or at least that's how it gets kind of polarized in social media. And I think that if you really talk to clinicians, it's not really this we only do talk therapy or we only do manual therapy, but it just gets polarized that
Right.
way. That's what I suspect. That's my hunch. Um, but you notice this on courses and conference circuits as well. It's not just social media. I keep saying social media, but um, but I think that what this systematic review has taught me is that we're not doing a good job of understanding and properly using outcome measures, which has the downstream effect of not getting to the right treatment efficiently and potentially adds a longer time to that positive outcome, as I mentioned. So there is a tendency to overutilize treatment trends of the hour and
Mm.
leave the others behind. And I think if we can really focus on doing a good assessment based on multiple measures across the spectrum, so psychosocial questionnaires or psychosexual measures, manual testing, testing using other objective measures, musculoskeletal, hip, pelvic, SI joint, whatever, and then interpret that appropriately. So this is a big problem, is the interpretation of that.
Mm.
Will arrive at the best approach. So manual therapy tends to be a lot of passive stretching type techniques. And if you tested the active component and it was negative, and your combined measure still showed stiffness, meaning the passive tone was greater, then that is absolutely the right treatment. Manual therapy is 100% the right treatment. So and maybe that manual therapy for one person is the right treatment, and mindfulness meditation is the right treatment. And another person needs biofeedback because they had higher activity. And this other person tested positive on these psychosexual measures, for instance. Um, or a combination of these treatments where the we would treat, the predominant aspect of the presentation. If everything was testing positive, what's testing the most positive?
Right.
So I think we need to be careful not to get into practice patterns or habits where we swing too far in any direction and stay there for every case.
Mm-hmm.
That's the problem. We need to consider the story of the person in front of us. We need to use the tools, the outcome measures, arm ourselves with a deep understanding of those. And unfortunately, this is not where our training system is at the moment. And I've just heard a lot of conversations about this, suggesting, as we talked about, that EMG is a waste of time, but are they? If it gives us the information we need to get to the treatment quicker.
Oh, well said. Well said. That's beautiful. Be flexible, individualized, science-based, and yeah, don't get stuck in the shiny loud noisemaker over here that right, all that like shiny stuff. Don't get too caught up with the shiny stuff. The stuff that looks very enticing and exciting.
Right. Go back to the basics. Keep it simple.
That's right. Keep it simple. Biology is complex enough, but the treatments, I always say, the treatments don't have to be. They don't have to be. This is beautiful. I am so thankful for you being on the show today, sharing your expertise, your wisdom, and your message of helping clinicians really start to shift the way that they practice and the way that they what they offer really to their patients. And you're right, we could do a better job of being more efficient. And if we use our outcome measures in the way that we not just to submit it for insurance or to do it because our institution is telling us to do and then never retest it again and never use it again. We just do it once. I fall in that trap too, but using appropriate measures, I think we would help people sooner, faster, and they wouldn't have to really rely on us for so long. That's really the goal, honestly, that they don't need us anymore. So, one thing that you had mentioned really quickly is the psychosexual measures. Do you have any favorite ones that you like to use or that you use with your patients?
I've not spent a lot of time investigating those. Those are more recent thoughts and conversations that I've had. There's a paper by Padoa 2021. There was a systematic review, or I think it's just a review report, part 1 and part 2. And they highlight these measures. So they highlight the measures that I've talked about, and then also have additionally added these psychosexual measures. And I've not spent much time in that space, but it is certainly something that I think we need to be considering. Because what do we do if this sort of construct that we've been living in for a long time of tone causes pain and pain causes tone breaks apart, and then what is the cause? And we need to start looking at these other concepts. Is it lifestyle factors? Is it perfusion? It's one of my favorite topics. Is it sleep? Sleep, of course, goes into the category of lifestyle medicine. Looking at sleep right now, which is really, I think, going to be cool. And tone goes away when we sleep. It should. And so if we're not sleeping, what happens to our tone? So we need to really, and then of course other musculoskeletal factors, but hormonal factors. We need to start looking at all of this more.
And really quickly, briefly, perfusion. You smiled and then you said, "I really love that." Could you explain that to us a little bit?
Yeah. Well, I think we've all, and I'm sure, I would imagine you've talked about this on the podcast, but we talk about the penis being the barometer for the heart, right?
Yeah.
And what we're talking about there is atherosclerotic plaques in the arteries going to the penis. And that actually being an indicator of maybe something more systemic, right? And if you look at populations of younger people, the first place that we start to see plaques form is in the abdomen. And if you think about the downstream effects, that arteries start bigger and then they get smaller. And so I'm really interested in this idea of getting oxygen to tissue and how that relates to lifestyle medicine, diet, exercise, and have some theories about about that. But one of the first things, I do a very extensive diet assessment. I think a lot of us do. I do a lot of education there, but I kind of base it around concepts of perfusion. And look, we have had this discussion for a lot of years about ischemia and how that relates to pelvic pain and pudendal neuralgia, right?
Yep.
But we don't talk about it in the context of atherosclerosis in the pelvic region as much. And we need to go there. Sciatica. That's one of the arteries that's downstream from where we know plaques form first in youth. So low back pain, everything, right? So we need to look at that.
Oh my gosh. So exciting. I'm so tickled. This is wonderful. I have to say, I'm geeking out over here. I love it. Thank you. You're speaking my love language. This is wonderful. Well, I'm speaking for myself. I cannot wait to read more of the research that's going to be coming out and all that you are all doing with your team there. And such a pleasure having you on the show. And thank you so much.
Nice chatting with you, Susie. Good luck.
Yeah, thank you. And Rachel, if folks wanted to connect with you, follow your work, where would be the best way to connect with you?
I'm probably the most active on Instagram, and my Instagram handle, do you call it that? So terrible at social media.
I think so. I'm also terrible.
Pelvic.fit with 3 I's. Pelvic.fit.facts. And the goal of that Instagram account is to really sort of bridge research and clinicians, but patients are certainly welcome to join into the conversation. It's just really boring. I'm not a Canva person. So if you want Canva images, don't follow me.
Don't come for the aesthetics. Is that what you're saying? Come for the facts, come for the knowledge, come for the truth, but don't come for the...
Come for the facts.
I love it. Yeah. That's awesome.
Don't judge my cute photo pictures.
Well, this is awesome. Great. Yes. Thank you. We will make sure to link your research, your Instagram handle, and certainly your full bio and everything in the show notes as well. So thanks.
Yeah. I'm also on Twitter at Rachel_Warman, but that seems to be kind of where researchers hang out, and I don't post there as much. So
no, that's awesome. That's great. Yeah, we do. We have this show is a combination of general public, but also of the clinicians and health professionals. So yeah, no, that's great. Anywhere that they can connect with you and your research, I think it's mind blowing. It's really awesome. And I'm really inspired to really change some things in my own practice to keep up with what we're learning. I'm really inspired. And to be honest, I'm going to be looking at some EMG machines. Ask you for your opinion. I'm going to be looking at that. I think it's great. And this has been very inspirational. And I think you're right. I think we can do a better job of being more efficient clinicians. And I'm inspired.
And prepare for your PhD.
That's right. Thank you, Rachel. Plug. Awesome. Well, thank you again. And to all of our viewers and listeners out there, I hope you enjoyed this show. As always, in loving wellness for your pelvis, this is Susie Gronsky. Until next time.
Thanks for listening to today's episode. Be sure to visit my website, drsuzieg.com, for show notes and related resources on today's topic. If you like what you're hearing, head on over to YouTube and subscribe to my channel. On my YouTube channel, you'll find content related to sex, pelvic health, and expert interviews for men. If you got a question or a topic that you'd like me to answer on my channel, be sure to type it in the comment box below.